of the union, plus we're international. So we didn't come in to this conference as a startup. This is our 28th year. So this is what we know about pain. Recognize this? Oh my God, I stubbed my toe. And this is what we know for sure. Swearing in whatever language you have will help relieve the pain. So that's the first thing we do. But in truth, the history of pain is the history of medicine. So, we're going to only go back to the 17th century of René Descartes. And he was the genius who said we have to deal with a political divide between religion and science. And this is the drawing of what the specificity theory said, meaning that you hurt your toe and it goes up your central nervous system to a specific center in the brain. I think, therefore I am, and today it's I am, therefore I hurt. So we all know this today, but we still don't necessarily accept it. We know that no brain, no pain. Everything goes through the brain, which is why pain management is neurological, but it's also psychological, it's also emotional, it's also cultural. Aristotle, Plato said it was an emotion because they couldn't see it. Our language does not really allow us to accurately describe it. And we're not necessarily great at being sympathetic to the pain of another person if we've never felt it. So the Cartesian Divide said, the physical and the non-physical do not communicate with each other. That the mind and the brain, the mind and the body don't communicate. And the deal was, we will give the mind to the church, the body to the brain, and finally I'm going to go back a little. In the middle of that is the patient's lived experience, perception, prediction, expectation, and when they all come together, we finally today have whole person care, meaning that your attitude and belief about who you are and your condition will greatly affect your outcomes. So what everybody wants is immediate relief. They want to go from whatever threshold they're at to zero pain, but more than that, they want to go to pleasure. So the current medications go up that central nervous system and block the pain trigger from even getting to the brain. So the magic pill theory is that somewhere there's a substance that if we take it, gives us immediate effective remedy for a disease or condition without any negative side effects. And the result of that is so many deaths from the opioid epidemic because the patient really believes that we can go from 10 to 0 on a dime. And that's not only not true, but it has been very difficult for us to regain our inherent ability to negotiate pain. So, what is the antidote? In the 1980s, research was done looking at post-cardiac surgery patients, some of whom had a window to a park, and on the other side of the hall, their window pointed to a brick building. And those whose windows had access to nature had 50% or more less complications. They left the hospital a day and a half earlier, and the use of nature began to be used and included in evidence-based design. So the positive distraction is now an actual clinical remedy for pain, anxiety, and stress. So the way it works is it draws our curiosity, it stimulates us, it's very easy and effortless. Well, what happens is, over time, if we don't have enough variety, we get used to it, we habituate to it. And then we're bored, and then the pain sets in again. So the answer is variety, re-engagement. And Nightingale said in the middle of the 18th century that the patients suffer more from looking at the same yellow walls, same unchanging walls, same unchanging situation. That the environment itself creates a sick room, and the lack of variety, lack of intellectual stimulation really attacks and makes worse the patient's condition. So what we want to do is create a toolbox for patients and have them discover what will work for them, but nothing works all the time forever. So now I'm going to introduce you to CareVRX. Our most recent product is virtual reality, where we can take a patient who's in a room, or a confined vet, or a confined elder. They put on the VR headset and all of a sudden they're at the beach, or they're in the mountains. It is gaze-based, so individuals who may not have the use of their arms, who may have IVs on both arms, which I had, can navigate different points of view or choose different scenes. So it creates an immediate wow, because you're out of where you were. It moves the patient outside of the home or hospital. The patient has choice to move or stay where they are. And the options include using the natural sounds of the environment, using music, or both. We also have guided imagery in English, Spanish, soon to be Hebrew, and in many other languages. And these are mainly narratives that help the patient engage in the environment. So CareVRX is based on the research and experience of the Care Channel. So we avoid in our pictures people, human artifacts. It is pure nature, as if you were in the environment. It's a 360-degree immersive experience. It has been shown to reduce stress and anxiety, and it increases effectiveness with use. So that means the familiarity of a positive experience. We want to do it again. We know where to go. And it puts the viewer into the middle of the experience. Our production team has shot it so that as you look out, it's as if you are sitting right there. So our primary considerations in the Care Channel and in all of our products is the content and the experience is appropriate across all ages, diagnoses, ethnic groups. It transcends all those things that divide us and really gets into our humanity. We minimize frustration and anxiety. We want it to be very easy to use. We prioritize the patient above the technology. And we want to provide beauty, wonder, and respite. And this is our 28th year. We've won many awards. We can partner with any of you to provide care content as part of your telehealth offering. You must sweeten the entry into dealing with healthcare, because it is all to date. No one wants to deal with it. We have to give patients something that increases and gives them a life worth living, something that reintroduces the beauty of wonder. Thank you.
Thanks, Susan. And that was a wonderful playing music. Do we have time maybe for one quick question? Yeah.
Yes.
Erica?
some different work that's addressing the loneliness of senior patients. So they actually put the patient in the crowds, like in the train stations and something like that. Can you comment on that line of work?
Yeah, this is what we found. First of all, we're looking at who's the viewer and what's their acuity level. Are they on medication? Can they hear well? Can they really see? Do they have bias where if we put, let's say, a very diverse group where they're African Americans and Indians and Sikhs, will that cause them stress? So we want to eliminate that. We want to have them be totally with nature, and of course, they usually where I think the optimal time in VR is about 15, 20 minutes. They can then be, it gives them a break. But the introduction of people sets up a whole way of reacting and responding in social situations that we may be completely unaware of.
Susan, thank you so much.
And thank you for having us.
Thank you.
Thank you.
So.